Dr. Anurag, Dr. Paul's action session for the pain physician in hard time of pandemic. Now I would like to introduce our speaker, Dr. Devendra Singh. He is consultant pain physician at hospital from last 10 years. He has done MBS from BRD Medical College, PNB from Hyderabad, PDCC in pain management from Mejanu, and FIP from US. His area of interest is spine interventions. Welcome, Dr. Devendra. Please start.
Thank you, Dr. Saldaram. And thank you, Dr. Vishnu. Thank you, Anurag boss. Today, am I audible to everyone?
Yes, sir.
Yes, sir.
I think my slide sharing from where it is possible.
No, I'm doing that.
Okay.
Yes.
Yeah.
Now you go back on the first slide.
How to go?
Click.
It's not clicking actually.
Just a moment. Where are you?
Yeah.
You are, yes.
Now it's okay.
Yes, please.
It is moving with the cursor keys.
Okay.
So now it is okay. So thank you all. Good morning to everybody. Today we on this platform, it's a very good platform. And it is a Made in India platform by our own colleagues and fraternity. Today we are here to discuss one of the most important step in our clinical practice, that is evaluation of an MRI, which is actually a very basic tool nowadays to evaluate your patient when you put on them imaging investigations, because this is the first step after your clinical examination and history taking. When you plan an intervention or to confirm your diagnosis, you always need an MRI, and very basic and proper interpretation is also very important, so that you are not in a mistaken part. Your diagnosis is correct and you are ascertaining that the features which you are seeing on MRI, which is responsible or which is the pain generator and which is a non-pain generating finding. So we go on the slides. So basic principle, I would not go into the much detail of the physics and the biophysical principles of MRI, but you can only for basic understanding, the MRI takes into the consideration of the potential hydrogen nuclei within the body to demonstrate a magnetic movement when placed in a large magnetic field. When we place a large magnetic field on the tissues, the hydrogen nuclei, it takes energy from the electromagnetic field, it resonates, it oscillates, and then it settles. When it settles, it again delivers the energy, and the different tissues which deliver the different energies have the different, depending upon the intrinsic character of the tissue. Each tissue has its own characteristics, times, so that the energy is redistributed. The larger molecules like proteins and smaller molecules like water do not exhibit efficient energy transfer, hence they have a long T1 times. They appear relatively dark on, that is the T1 weighted image. The fat has efficient energy transfer, so they have the shorter time, and therefore the brighter image, T1 image. And in general, in all MRI pictures, the T1 images are mostly in the sagittal plane and T2 images are both in the axial and the sagittal plane. But nowadays it is not very exactly because we see the T1 and T2 in both the sagittal and the axial planes. So if you see the T1 images, we see properly the basic anatomical structures like neural foramen, nerve roots, disc, herniations, and metastatic disease can be visualized on the T1 images. And T2, because of its enhanced CSF signal, it is more sensitive to the pathologies like tumor, infection, osteomyelitis, discitis, etc. So in general, we have to see both the images carefully, because the T1 images illustrate the details of anatomies, whereas the T2 images provide information about the disease process. First of all, when a patient comes in your clinic, you take the detailed history, you proceed with the examination part, and because here in this presentation we are more focusing on the low back pain and the lumbosacral spine, regarding the interventions, regarding our diagnosis and the MRIs. So when we examine the patient, and when you decide, after making a tentative diagnosis, that what is the cause of the chronic pain and what may be the probable diagnosis, then you decide whether to get an MRI done or not. Evidence has suggested that because many of the findings are asymptomatic, that you don't suddenly jump on the MRI. There are, when it is appropriate to do an MRI, there are red flags. It is the American College of Radiology and the different neurological societies of the world have decided few red flags which you have to consider while taking into the consideration for getting an MRI done. Those red flags are like significant trauma, unexplained fever, weight loss, immunosuppression. There is a history of neoplasm or IV drug intake or chronic steroid use or osteoporosis, or if it is the age more than 70 years. These are the red flags where you get immediately an MRI done, and you don't wait for like 2 weeks or 4 weeks for treatment and then you get an MRI done. You can immediately get an MRI done if there is any of the red flags present in the patient. Then these are the different agencies. Agency for the Healthcare Research and Quality, they have also told that if there is no red flag, then also suppose the symptoms persist for at least 6 weeks, or the prolonged pain is prolonged and unremitting in spite of your treatment, or if it is of radicular nature and accompanied with a motor dysfunction or cauda equina or a myelopathic findings, then also you have to get an MRI done immediately. And over the past decade, MRI has become the premier imaging modality due to superior contrast resolution and improving spatial resolution. MRI can always detect the active inflammatory process of a degenerative or infectious origin. So this, if you see this image, this is about the basic anatomical reading of an lumbosacral spine. I have showed the two images, that is age of 2 years or age of 18, that is one is the child and one is the adult, and both are T1 images. In T1 images, you can see the CSF black in color, spinal cord grayish in color, and if you see how the anatomy changes from the child to adult, you see the disc space are less in the children at the age of 2 years. Gradually the disc space increases, disc height increases. There is a very weak annulus is there, and the nucleus part is much larger in the children, and gradually, if you see in different T2 images, you see the annulus has become thickened and the nucleus has concentrated in the center only. Then you see the ending of the spinal cord. You can see the spinal cord going up to, it can go down here up to, and in the adults you see the spinal cord ending at L1, L2 level, and after that there is a only the roots coming out of the cauda. So there are some basic changes you see in the, and you can see the bone marrow. Bone marrow, it is showing the low signal intensities because it is more of a, there is more blood in the, and when the age grows, the bone marrow is infiltrated by fat, and so it has the brighter image on the T1 due to the fatty change of the bone marrow. And this is the spinous process, the sagittal view of the spinous process. In between there are ligaments, and this is the normal T1 image at the basic level of the 2 years and the 18 years. And when you see the T2 image, this is the T2 image. Now you can easily see because the water content is bright now. Roots are also very clear in this. So you can see the extent of the thecal sac up to the L4 level here. And here the thecal sac is ending at the L1, L2 level. After that, only the roots are coming down. Here you can see the thecal sac ending up to the L3 level. So this is the difference. You can see the water content of the disc. The annulus is very thin out and the nucleus is larger. It is extending up to the end of the disc. And here the nucleus is in the center and outer 1/3 of the disc is only the strong annular fibers, which you see the black. There are also the marrow infiltrations, the fat by fat. You can see here clearly, and there is no fat. Only the hemopoietic tissue is there in the marrow of the children. And you can see here the changes in the spinous process also, in the ligaments also. This is the fat again above, subcutaneous fat which is showing. So this anatomy is very important. And what are the changes when the age grows from 18 years to 40 years and to 80 years? You again see the different changes. We will discuss in the further slides. So what is the normal MRI? What features are normally found? The height of the lumbar disc increases from L1 to L4, from L1 to L4 here, and the shape is concave. L5 disc, this disc shape is variable. It can be convex also or flat from posteriorly also, and the contour can be variable. L5 disc. Interpedicular distance increases as you go the caudally, and the shape of the lumbar canal is almost triangular in shape in the 90% cases. And lumbar canal dimensions, this I have mentioned because in MRI, when it is written, the pain physicians should also interpret what is the cross-sectional area, what is the minimum AP dimensions, minimum interpedicular diameters. So at least if you know the basic anatomical things, then you can assess how it has been changed in your patient. What are the diameters which becomes, when the patient becomes symptomatic, what are the diameters? Sometimes you see the very less diameters and still the patient is not symptomatic. So these are all findings which you have to interpret in the light of your clinical features. Then this is the axial view. This is the axial view of the lumbosacral spinal segment. Here we can see the facet joint. Facet joint has a parasagittal orientation in the upper lumbar region. Parasagittals means they are almost parallel to the sagittal view, like they are almost horizontal. But as you increase the below lumbar, they become little bit coronal or oblique shape. I'm talking about the facet joint. Facet joint are on the upper lumbar. They are almost straight, parasagittal. But as you go down, they become almost oblique. This obliquity you can see. This is the upper lumbar region, so it is almost a parasagittal in their distribution. Then when you go down lower lumbar, they become the coronal or oblique in the orientation. And on axial image, the facet joint, this is typically a curved comma-shaped joint. The SAP is situated in, this is the superior articular process. It is anteriorly and laterally, and this is the inferior articular process. The posterior, this is the posterior ligament complex, where there is interspinous ligament, ligament facet. This is ligamentum flavum, the dark color in internal lining, and it is also supported by the facet. The ligamentum flavum is fused with the facet joint capsule here. And here only, this is the spinal canal, triangular shaped spinal canal, and this spinal canal has the cross-sectional area of AP diameter of 11.5, typically the lower lumbar segments, 11.5, and the cross-sectional area of about 1.45 centimeter squares. And the interpedicular diameter is also about 16 mm between the two pedicles. So this is, I think now it is better. So this I have already discussed. The tip of the conus is at L1 or L2, and the L1, L2. As the segment root leaves the thecal sac, it is encased in a root of sleeve of variable length. It enters the lateral recess or the subarticular space seen on the axial MRI. This I'll explain in the another slides, in the next slides. The nerve always passes inferiorly to enter into the intervertebral foramen, which is a teardrop shaped foramen with the widest diameter superiorly. If you see like this, the tip of the spinal, the conus is at the L1, L2 level, and then each segmental root leaves the thecal sac, and when it leaves the thecal sac, it is encased in the sleeve. The sleeve is encased in the dura mater comes with the sleeve, and it enters the lateral recess. Here in the next slide, I will show how the lateral recess and the foraminal space, and then the nerve passes laterally and inferiorly to enter the intervertebral foramen, which is a teardrop shape, like this. The first, it is in the central canal, then it passes subarticular, that is below the SAP, and then it passes more laterally in the foramen, and then it comes out. In the next slides, I will show you. MRI is helpful in evaluation of the following: degenerative diseases of the disc leading to the disc herniations, central canal stenosis, lateral recess stenosis, foraminal stenosis, then the facet joint degeneration, for example, the synovial cyst also, and the degenerative spondylolisthesis. Then it can be useful in inflammatory spine diseases, in spine traumas, compression fractures, pelvic fractures, pseudoarthrosis, then spine infections, then all the other malformations, spinal neoplasms. MRI is useful in each and everything. Then the lumbar degenerative diseases. The spondylosis deformans is a term used to explain the normal aging process, the changes which occur in the MRI, which you can see in the MRI due to the normal aging process. And if it is a pathological, then it is known as intervertebral osteochondrosis. Now you can see that T2, and this is a T1 image, this is a T2 image. B is the T1 and this is the T2 image of a 77-year-old. You can see the normal loss of, even in the T2 image, the normal signal intensity in the disc. Because of the loss of the water content in the disc, there is a loss of normal signal intensity in spite of the T2. There is preserved disc height. It is absolutely a normal patient where the disc height is preserved. There is no significant degenerative changes. There are the changes which are being seen. There are only due to the age of 77-year age, and the normal heterogeneity of the bone marrow which occurs in this age, you can see here both in the T1 and even in the T2 image. This is a normal scan of a 77-year-old woman. Then this is intervertebral chondrosis. This is exaggerated degenerative changes which are there, and same age, almost the same age. It is 71-year-old man, and he's presenting with the low back pain symptoms. Now you can see there is extensive loss of disc space. If you see, this is also a 77-year-old woman. There is preserved disc height in this, but this is where the disc height has extensively decreased. There are type 1 marrow changes in this. There are also the radial tears. You can see here the radial tears and the annulus. The nucleus the nuclear material is going up to the outer 1/3 of the annulus, and sometimes when you see there is an annular tear here and the nuclear material has got surrounded by a granulation tissue here. You can see a bright spot here around the dark peripheries, which is known as high intensity zones. It demarcates the healed annular tear. So these are the degenerative changes which occur in the old age. And then there is deep degenerative modic changes, which are described peridiscal and the marrow changes. This is of 3 types. type 1, type 2 and type 3. And this is very important to recognize, because the modic changes are very similar to the inflammatory process changes. If you see the MRI of two patients where there is an inflammatory process and where there is no inflammatory process, I mean the modic type 3 changes and type 2 changes, they mimic very similar to a severe inflammatory process. And sometimes when you are a novice in MRI reading, you see the MRI and you think, oh, this is a very bad MRI. But most of the time, those changes are the modic type 3 changes or the degenerative changes. In type 1, there is an ingrowth of fibrovascular tissue. There is into the marrow. You can see the intervertebral space also. There is a fibrovascular ingrowth of the tissue. And when you see the signal intensity is decreased in the T1, and there is a narrowing of the disc space. These are categorized as type 1 modic changes. And when you see in type 1 changes, the T2 signal intensity is increased because of the fibrovascular invasion of the marrow. And this is the post-contrast image. This is a post-contrast. There is a marrow enhancement also. And you can see all the tissues here are having uptake of contrast, and they show the enhancement. Then these are type 2 changes. In type 2 changes, there is fatty infiltration. There is little bit increase in the signal intensity of T1 and both T2. But if you see the interspace region, there is no enhancement as it was here. This is enhanced, but in modic type 2 changes, there is no enhancement in the interspace area, intervertebral space area. And the type 3 are the sclerotic changes. Type 3 sclerotic changes, there is decreased in the T1, and in both T1 and T2, there is decreased signal intensity. This is type 3 actually. This is type 2 changes, and these are type 3 changes. And in type 3 changes, you see decrease in the signal intensity both in the T1 and T2 images. These are the disc herniations. This is a normal disc. This is just a diagrammatic representation. This is a diffuse disc bulge, broad base protrusion. When the circumference is 20 to 50% of the disc, it is known as broad base protrusion, because these terms are always written in the report of MRI. When the radiologist describe you should know what it is meant by the diffuse bulge, what is meant by the broad base bulge, what is focal protrusion, what is extrusion. And even sometimes when you are very clear, even if the report is not well written, then also you can write in your clinical findings, in your prescriptions, how the MRI is describing it. So you should know about all these terminologies. What is broad base bulge? What is focal protrusion, where the diameter is less than 25% circumference? Where there is extrusion, where the neck is less than the extruded fragment, diameter of the extruded fragment. This is sequestration. This is entirely disconnected. There is a loss of contact with the parent disc, and the sequestrated fragment can be lying in the canal or in the epidural space. This is description in the sagittal plane. This is a protrusion. This is an extrusion with a down migration of the fragment, and this is a sequestration, extrusion and sequestration. So this is a diagrammatic picture. This type of image you see in the MRI. So now you see this patient has a radicular pain, and when you see the MRI, you can see the L4. This is hello.
Doctor, yes, please go on.
This is right L4 protrusion. This is the axial, and this is the axial, and this is the sagittal view. And you can see here that there is a protrusion here, and the right side. This is the right side. In MRI, always what is your left side? It is on the right side, and what is your right side? It is on the patient's left side, as in the CT and both in MRI. You see the inverted image. So here it is the right side, and the right central and the subarticular. This is a central, and this is a subarticular space. Subarticular means below the superior articular process. At the level of the superior articular process, subarticular disc protrusion increases, and here it is where the traversing nerve root lies, and so the protrusion is encroaching upon the traversing root, and the patient has a L5 radicular pain. The disc is L4, L5, and because it is protruding, because it is compressing the traversing root, this patient will have the symptom of L5 radicular pain, not of L4. Suppose the herniation is in the more lateral herniation, suppose it is in the foramen level here, if the herniation is here, then it would have been encroaching upon the exiting root, which is exiting on the L4 level, L4, L5 level. If it is encroaching on the exiting root, then the symptoms might have in the L4 distribution. But when it is encroaching upon the traversing root, the patient has symptom on the L5 distribution of the lower limb, of the right side lower limb. So this is very important to differentiate in both the axial and the sagittal image. And this is another example of central L5 extrusion here in the straight arrows, and you can see the curved arrows which show the displacement of the nerve root. This is the displacement of the nerve root. This is also the displacement of the nerve root, and this is posterolateral extrusion. You can see here the annular margin is closed, it is healed off, and some extruded material with the granulation tissue, it is extruded out in the canal, and it is directly encroaching the traversing S1 root. Here, this is because this is L5S1, you can see the sacral L of the sacrum here, both sides. So in this view, you can confirm that is in L5S1 position, and you can see how the inflammation has surrounded the traversing nerve root, and the nerve root is displayed and severely affected by the extruded fragment. So now, which I was telling about the, suppose you see here, this canal, when you see in the diagrammatic picture of in the bony context, is like this. So this is the central canal zone. This is the subarticular, that is below the superior articular process. This is the subarticular zone, or the lateral recess zone. I must tell you that this is the zone where you doesn't see the disc bulge too much. In the sagittal disc, if suppose the encroachment is only in the lateral recess area, and the central part of the disc is normal. So in the sagittal view, when you see the cross section across this view, you may not see the disc bulge, and you may feel that the MRI is very much normal, but the patient is very much symptomatic. But when you gradually see the sagittal view, of all the sagittal view from the left side to the right side, then when you see the image in which there is a subarticular plane, then you can analyze in the sagittal view that there is a compression or there is an entrapment of the nerve root in the subarticular or the lateral recess area. And in the axial view, it is better clear. In axial view, it is always clear that the lateral recess area is encroached. And this is one area where you see the patient most symptomatic, because lateral recess is a place where the nerve root is actually entrapped in the foramen, and more than foramen, in the lateral recess, the entrapment is more severe in this lateral recess, because this is a very small place. Foramen, if the fragment becomes exteriorized, then patient may have less pain. But in the lateral recess, it is entirely entrapped in the canal, and the patient is too much symptomatic always. Then this is the pedicle, below the pedicle. If the fragment is below the pedicle, it is in the foraminal zone, and mostly here the compression will be of the exiting root. Like this, you can say this is the exiting root, this is the exiting root, and this is the traversing root. If it is in the foraminal level, then your traversing root will be spared and the exiting root will be compressed. And if it is in the lateral recess area, then your traversing root is more compressed. So this is the foraminal area, this is the lateral recess area, that is the subarticular zone, and this is the central canal area. Central canal area, when there is a bulge and there is a compression on the thecal sac here, you see the more or less the symptoms that they are bilateral, and the symptoms are of more or less lumbar canal stenosis, that is the neurogenic claudication. You feel the patient is doing his activity, but he is not able to walk or stand for a prolonged period. He may feel that his lower limbs or the legs are there, he is feeling stretching pain or the fatigue, he can feel the fatigue and he can sit after walking for 10 to 20 meters or 100 meters. So this zone of displacement is very important to recognize in MRI, and it also determines your endoscopic intervention also, how when the fragment is lying in the central canal, when the fragment is lying in the lateral recess, or the fragment is lying in the outside, that is the foraminal zone. It is very important to decide and plan your endoscopic intervention according to the zone of displaced material and the zone of compression. This is again the subarticular focal protrusion, and there is a compression over the traversing root. This is exactly where we call the lateral recess, and here also we see the compression over the S1 root, S1 traversing root, and the patient will have the symptoms in the S1 area. And accordingly, you can see your reflexes also, and your tendon reflexes also, and the sensory loss also. Almost it will correlate, always it will correlate with your MRI findings. Then we come with the central canal stenosis. Central, it is mostly it is a degenerative, it is the encroachment of the central canal. As I told, the central canal anteriorly, central canal is anteriorly encroached by the disc, and posterolateral by the osteoarthritis of the facet joint. There is a loss of disc height space. There can be buckling of the ligamentum flavum posteriorly. There can be epidural lipomatosis, which you can see here, and this also can could put a pressure on the thecal sac and the roots. And then you see the cross-sectional area of the lumbar canal. In this case, there is a severe compression at the L3 or L4 level here. Both these places, there is a severe compression or the narrowing of the central canal from anteriorly and as well as the posteriorly. From both sides, it is being narrowed. But there is no focal protrusion here. If you see the axial image, there won't be any focal protrusion here. This I was telling. This is facet. This is the facet joint hypertrophy. Here also you can see the facet joint hypertrophy. This is epidural lipomatosis, where the fat is all over the epidural area and the thecal sac is distorted. This image is I'm just showing for the how the dye spreads in the interlaminar area. So these all present with the features of lumbar canal stenosis. Here you will not show, here you cannot see the focal tear or any focal fragment, but you will have the symptoms of lumbar canal stenosis. Yeah, this is this in the AP. You can see there is a congenital narrowing of AP dimension here because of shape of the facet joint and the shape of the pedicle and the spinous process. Then this is because of canal narrowing due to the short pedicle and the facet joint arthropathy and the ligamentum thickening. Here there is a ligamentum thickening also. This is a severe canal stenosis. Here also there is a severe central canal stenosis due to the facet arthropathy and the ligamentum flavum, and here there is an annular bulge also. So all the three things are here. So these are the factors which contribute to the central canal stenosis. Then because of chronic steroid therapies, like patient is on autoimmune diseases or spondyloarthropathies where the prolonged steroids have been continued, or any other endocrine abnormalities, where there is a epidural lipomatosis due to the endogenous increase in the steroids. So this is you can see the dorsal epidural fat, multiple segments. It is full. The epidural space is impacted with the fat, and it is showing the deformed thecal sac, and it is presenting the pressure on the thecal sac. Here also you can see the deformed thecal sac or the concave thecal sac. Epidural lipomatosis is a common finding you see in MRI, but you have to always examine the patient and see how much the patient is symptomatic with this. But most of the time in the severe epidural lipomatosis, the patient is symptomatic, and you have to find the cause of the lipomatosis, that what are the endocrine changes which are there in the patient. Then this again is the lateral recess. As the root leaves the central canal, passes caudally and laterally into the lateral recess area or the subarticular zone. This is basically a stenosis produced at the level of the facet joint. Lateral recess stenosis. This is a common term which will be written in the MRI reports, lateral recess stenosis or the lateral recess narrowing. You have to understand here the facet joint is the main culprit, and these patients are always chronically symptomatic, low back pain as well as a radicular component. And here there is always osteoarthritis, there is overgrown of SAP in these, and the axial view are the best seen and the best analyzed. This is again showing the right-sided facet joint impinging on the S1 root. And this is where you have to plan also. When you plan your endoscopy, then also you plan what to do. If there is lateral recess stenosis and you only enter into the disc and you take out some material from the disc, it won't help unless you address the cause at the level of the facet joint. So you have to enlarge the lateral recess area. That is, you may have to do a partial foraminotomy or the facet joint reaming, or you have to increase the space at the level of the lateral recess. Then only the patient will become asymptomatic. So you have to be very careful in planning your endoscopic intervention when there is a lateral canal stenosis, and especially when there is a lateral canal stenosis and there is no significant bulge or the tear. There is a mild diffuse disc bulge along with the lateral canal stenosis. Then you have to plan it differently, your endoscopic intervention. This is almost same thing. Then the nerve root after coming from the lateral recess, when you go more lateral, and it is going the laterally and caudally and enters the transforaminal zone. This you can call the transforaminal zone, because here is when you place the needle in this zone only. You place your needle when you place your transforaminal steroid. It is the foramen is always teardrop shaped, and exiting the nerve root is situated in the superior most part of the foramen. And this is an extraforaminal space. This is a far lateral zone. Rarely, sometimes you see the fragment migrated into the extraforaminal space also, and the patient is severely symptomatic. This is also the special case where you have to plan your approach. It won't be inside-in approach, and you have to be either 50-50 approach, or you have to be an outside-in approach to deal with the fragment in the extraforaminal zone. This is again the foraminal sclerosis, which is a disc extrusion, and you see the migration of the material into the foramen, compressing the exiting root, and also the degenerative conditions like osteophytes and synovial cysts, spondylolisthesis, and facet joint hypertrophy. This is L5. Here you can see the L5 foraminal disc extrusion. This is foraminal disc extrusion. Whole of the L5 disc has got into the foramen. This is L4 foramen. This is L5 foramen. Here you can see the whole of the disc has much of the part of the disc has got extruded and impacted into the foramen. This is the foraminal extrusion, and it is lateral to the lateral recess area. This is a pure facet joint arthropathy. It can be acute. We can see this is a normal facet joint without inflammation or effusion. This is a facet joint which can be symptomatic. There can be always a tenderness. Paraspinal, when you see elicit the tenderness, you can find easily the tenderness, and patient has pain in extension of the spine. And this is the fluid in the facet joint or the facet joint effusion. And in the post contrast, if you see this acute facet joint inflammation, you can see the marrow edema also. You can see the marrow edema and in general edema in both the articular process. So facet joint, most of the 30 to 40% back pain without radiculopathy or with minimum radiculopathy are the patients of the facet joint arthropathy. This is one of the degenerative condition of the facet joint only, and which is known as synovial cyst. This is a degenerative condition from the facet joint where there is a history of trauma, or it can be degenerative also, where there is a defect in the fibrous joint capsule of the facet joint, and there is an expansion of the synovial or the outpouching, and which is no longer constrained by the fibrous joint capsule, and it becomes a cyst. It becomes a cyst, and it may lie in the canal, and it may cause a severe radicular pain or claudication or the axial low back pain. You can see in the axial plane, this is a synovial cyst, and it is lying in the central canal, and it is always also compressing the traversing root in the central canal. And you can put the needle, and you can locate easily. You can fill the dye in this synovial cyst, and you can see the spread of the dye, and you can aspirate this dye, and then you can put the steroid in the transforaminal area. But this synovial sac, always it will compress the traversing root here, synovial cyst. Then there are degenerative spondylolisthesis due to the abnormal anterior or the posterior displacement of the one vertebral body over the another. In this, MRI is diagnosed, but in this always the investigation of choice is a lateral lumbosacral spine X-ray with the flexion extension view, so that you can grade the level of the displacement, that it is level 1, level 2, or level 3, or level 4. And it is a enterolisthesis or it is a lateral listhesis. It is associated with the central canal stenosis or not. This all you can combine your diagnosis according to the X-ray and the MRI both. This is one of the entity where Bastrop syndrome, not very much important, but it was there, so I would like to tell you that it is an imaging finding in which the lumbar spinous process contact in extension, and with radiographic evident sclerosis and flattening of opposing bony surfaces with the pseudoarthrosis formation, which may be accompanied by pseudobursa, and the patient may have the severe low back pain. Here you can see the spinous process of L2, L3 and L3, L4, they oppose each other. So not very important. And this is post-contrast enhancement of the same Bastrop syndrome. There is a post-contrast enhancement, and this is also relieved by the interlaminar or the interlaminar injections of the steroid. This painful condition. And if you see the bone scan also, there is a significant uptake in the level of the spinous process of L3 and L4. Then this is another rare, but sometimes you can find this is also Bertolotti syndrome. It describes the presence of the transitional lumbosacral segment, where there is the disc is rudimentary, but another you can see here also, and there is a pseudo articulation of the transverse process and the ala of the sacral ala. This is another joint form, but this is sometimes it can present with the low back pain, which may mimic the sacroiliitis pain. This is why it is important. That stress or the trauma may mimic the sacroiliitis, but it is a degenerative transitional lumbosacral segment, and the disc is almost not found in this level. MRI can detect the seminal abnormalities within the cord, which may serve as a marker of cord edema or the venous hypertension too. In osteoarthritis of the thoracic facet joint, MRI detects the marrow edema in the articular process or the joint division. Post-gadolinium contrast images can demonstrate active inflammatory disease in the thoracic facets or the costovertebral joints. Now we come to the basic endoscopic spine instruments which we use commonly, and there are many instruments which have come up, and gradually new instruments are coming up, but these are the basic endoscopic spine instruments which you use when you initially start placing your scopes. So percutaneous spine endoscopy is now considered a pinnacle of minimally invasive spine and pain interventions, and all the spine pain physicians do currently, and I'm glad to tell that most of the best pain and spine interventions are not from the ortho or the neuro side, but one of the best spine interventions. Nowadays the spine and pain physicians are doing the very good interventions, and now they are publishing also. Dr. Anurag boss is there. He knows, and he'll tell you how the nowadays the spine and pain physicians are venturing into the percutaneous spine endoscopy, and they are really doing very good jobs. So this is perhaps the only minimally invasive pain and spine interventions which we have nominated the term MIPSI, where the proof of efficacy is objective. Always pre-op you can test the patient, and immediately post-op you can test the patient, and patient himself tell you the success story, that how is he relieved after the span of 1 hour. So, but spine endoscopy definitely require the learning curve, and but once you start it, gradually you learn, your case selection becomes better, and then your results are also better. And spine endoscopy requires some special equipments, and we always thank to the original developers like Anthony Young, Thomas Hoagland, and others who have developed initially these scopes and the instruments. So these were the initial rod lens endoscope which were used, and it were used for all the approaches and different size and the different routes. But now for the different approaches, there are the different scopes, whether it is an interlaminar or it is a transforaminal, the scopes are different which are available. This is the basic scope, rod lens endoscope, which contains a working channel here. These are the light source. One channel is for irrigation of the fluid, and one channel is for the suction of the fluid. And this is the camera. This is the camera which shows the working area. And they have tapered angle, and usually for foraminal endoscopy we use the 25 or 30 degrees scope. You see the vision, which is the object is located at the 30 degrees from the tip of the camera, which you can easily see in the front of your scope. And initially, when you place the needle, and then the needle is replaced by the K wire, and then you place the dilators. These dilators are conical dilators. They are passed over the guide wires, and there can be serial dilators also, and there can be single dilator also, depending upon the type of set you are using. And after this dilator, these are the working sleeves. working sleeves are usually of 7.5 or 8 millimeter for the transfemoral root, and there are blunt working sleeves also. There are tapered, and these mostly the tapered ones are most used because you can turn these sleeves while entering into the canal so that you can save your exiting route. This cut also act as a shield, and another advantage of this tapered end is that you can, when your sleeve is in the half of the sleeve is in the epidural space and half is in the disc, that is the annulus, half has closed annulus, then you can see the 50-50 approach, 50-50 view, and you can see the extruded fragment which has come out of the annulus also. So it has multiple uses because of this, the sleeve, because of this the tapered sleeve. And after putting the working sleeves, then you push your scope, and then you put your, and these are the different cutters. This is an annular cutter basically, and suppose the annulus is the disc is extruded or the fragment has migrated, then you, because only little bit of the extruded fragment can be seen outside and the rest of the fragment is inside. Then to deliver that fragment, you have to cut the annulus, and then only you can deliver the remaining fragment. So there are different type of cutters also. There can be short end, there can be long length cutter, and these are the punch or the annular cutters. And these are the nerve hooks. They are the blunt tipped instruments, and when you use these, you can separate the neural structures from your fragment, because if there is a chronic inflammation, the neural structures are always adhered to the fragment. Then you have to very carefully probe the nerve root or the suspected neural fragment. Hello?
You're joining this London.
Hello?
Continue. Please,
Okay.
Please go on.
So these nerve hook are used to probe also the neural fragment, neural tissues, and these are used to separate also from the neural tissues to the adhered fragments. So these are also very useful. Then these are the endoscopic Carrison punches. These are for stenotic lesions when you want to cut or scrap the suppose ligamentum flavum, or you want to very tough structures, or there is a calcified annulus, then you use to these Carrison punches to cut, and especially most of the time they are used for the foraminotomies or the stenotic areas. To approach the stenotic areas, you have to widen out the area and to improve your visibility and to catch hold of the fragment, then you use these Carrison punches. And these are also instruments used for foraminotomies when you need to widen the foramen to shave the margins of the superior reticular process. You need to widen the foramen, and or sometimes also used for the calcified disc, but mostly used for the foraminotomies for the for cutting the bony fragment. So not used very frequently, but in the cases of lateral canal stenosis, when you want to widen the foramen, then these are the curate, these are used. And these are the sequential reamers. They are also used for the widening your opening. Then the tip is blunt to prevent the injury, and they are of different sizes, which can be from 2 to 9 mm sizes. And these can be, they can make your pathway through the bony canal also, or you want to ream the facet also to make your path up to the fragment. So these are the reamers basically used to ream the bony structure. And these are the grasper. When you reach your fragment, these are the grasper different use. There are curved grasper, there are small length, large length, or there are curved where you can suppose the fragment is migrated and you are straight, your straight grasper is not able to reach, then you can use the curved grasper to catch hold of the tip of your fragment. And they can be without the denticles, or they can be smooth grasper, or they can have ridges or the denticles made in this so that the fragment may not slip and you can easily catch hold of the fragment. This is important, that is a endo RF cautery, and this is of high frequency, almost more than 4 megahertz, and it can be used in very close approximation to the neural structures, because these are the procedures where you play very nearly to the neural structures, and it is also used for thermocoagulation also, for stopping for bleeding, and also used to clear the field also, where all sort of tissue, fibrous tissue, connective tissue, or you want, there are many, it's used for both the coagulation as well as the hemostasis, and it is safe because it's very high frequency, so very low wavelength it has, and it can be very safely used around up to about 0.6 millimeters nearer to the neural structures, and the neural structures are always safe with this cautery. These are the drill. There can be power drill, and the tip can be diamond or carbide. They can be straight. These are again used to drill or clean the bony structures so that you can make your way or widening of the foramen. These are used, and this is a guarded. This is a high speed burr, and this is the burr with the guarded, so that it protects the nerve root structures, and the root may not be damaged when you are drilling or when you are reaming the bony structure. And they can be moved. The tip is movable, so these burr are very useful. Then this is the endocam whole trolley, where you need a medical grade monitor, the light source, camera, and all these things which are used in other endoscopic or laparoscopic procedures. Hello. And this is a complete OT setup, where there is an anesthesia station and your fluoroscope and fluoroscope monitors, and this is the endo trolley. This is the endo trolley and all the emergency drugs. This is the whole setup for the minimally invasive pain interventions and the endoscopic interventions. Thank you, everyone. So, hello.
Thank you.
Hello.
Dr. Hello.
Yes, Dr. Sarita ma'am, please.
Thank you, Dr. Devendra, for a very nice, elaborative lecture. And now I am requesting Dr. Anurag for question answer.
Sir, Devendra Singh sir, it was indeed a very nice lecture. Thank you very much.
Thank you, Dr. Krishna.
Thanks a lot, sir. And Anurag sir, your opinion, please, sir.
No, it's a wonderful attempt to make the importance of MRI reading by all the pain physicians. Thank you, Dr. Devendra, for that. And we all believe that without, if you don't read your MRI yourself, you cannot do good interventions.
Definitely, sir. Definitely.
Dr. Vishnu, Dr. Devendra, please, there was some technical disturbance in your last two slides. So there is a request from Dr. Murli. Can you please show again your last two slides? One more, yes. Yes, please say a word about it. Yes. Start from here and complete.
So this is the high speed drill. This is a power drill used by the pneumatic compressions, as you see in the orthopedic procedures. But those are the big drills. It can be run by the carbon dioxide also, and it can be run by the air also, or it can be motorized also. And these high speed drills of the burr are used basically for the foraminectomy procedures, or where you want to clear the structures, and it is taking very long time if you do manually with using the forceps or the reamers. So it is better than reamers, the burr is more faster and more, but they are very powerful burr. So you have to be your learning curve should be at such level though, so that you can safely use these burrs. And the tip of burr can be it can be adjustable like our other forceps and the holders. And it is also the burr, these are the guarded burr which you have there is a neural protection also, so that the one side the neural structures can be saved, and other side you can drill for your assess for the endoscopic instruments. So this is a regular endocam tower, which includes the medical grade monitors. This is the light source, and this is the camera modulator. And so these are the basic instruments which are used for the endoscopic intervention. And this is a general our anesthesia workstation, the C-arm, the monitor, and the endoscopic trolley. This is the complete OT setup. Yeah, am I audible?
Sir.
See, there are many other instruments which have come up, and as the endoscopy is more and more experts are using the procedure, and with more and more wider indications, the industry is also developing more and more instruments according to our use. So suppose we are having problem in one instrument, the industry is also driven by our requirement, and it is also they are also making the instruments according to our requirement and according to the problem we face during the procedures. So more and more instruments are coming up, and the different companies are giving different things. So, but these are some basic instruments which you will definitely need in the basic endoscopy procedures.
That's great. Yes. Dr. Vishnu, please take the questions from the audience. There are few.
Yes, sir. First thing from Shivani ma'am. Ma'am, you have asked a question. What is the importance of interpedicular distance?
Dr. Devendra?
Yeah.
Please, all these questions are for you only.
Okay, yes, okay. 1 minute, I shall go back to the... See, importance of interpedicular distance is that if the interpedicular distance is less, then the canal is less wide, then the patient will be symptomatic more early. If interpedicular distance is more, the canal is wider. These are the pedicle. This is a natural distance. So if this distance is less, then the canal space is naturally low, and these patients will have quicker symptoms with a lesser degree of disc bulge or the canal narrowing. They will have symptoms very early. So this is only the importance of interpedicular distance.
Fantastic, sir. Sir, one more point I would like to add. And if you see the superior surface of the facet and the superior border of the neural foramen, which is formed by the pedicle, here this is the point where the ligamentum flavum attaches. Okay, and it also extends downwards. So in case of calcification also, the interpedicular distance comes down, first point, and this serves as a prognostic factor for lumbar canal stenosis, that is the grading of lumbar canal stenosis. The second point is that in case of burst fractures of spine, there we have increase in interpedicular distance, so which helps in management also, so that to align our Tomsteady needle, it will be very helpful.
Yeah. Thank you.
That is a great point here.
Yeah.
Sir. Thank you, sir. And next question, sir. Samriti ma'am, ma'am, you have asked a question. What are Tarlov cysts?
Tarlov cysts is also a degenerative condition.
Yes,
they are also a degenerative conditions of body, and I don't think much of the very clinical significance is that of Tarlov cyst.
Yes, sir. Sir, actually, from my experience, I would like to share one case. I typically had a patient with S1 radiculopathy, but she did not have any MRI or something. She was typically having S1 radiculopathy. And when I asked for an MRI, basically she was having a Tarlov cyst. Ma'am, Samriti ma'am, actually the Tarlov cysts are nothing but these are fluid-filled nerve root cyst, and basically arises in the sacral region, and it is always present posterior to the sacral nerves, and it can cause compression of the sacral nerves, and it can cause saddle anesthesia as well. So basically there is no scope of, maybe for MRI reading wise it can be a diagnostic purpose, but as far as the interventions are concerned, this generally requires a neurosurgical intervention, ma'am.
Yeah. That's very true actually. It has been advisable because most of the Tarlov cysts are connected with the intrathecal space. So they are like the fluid filled balloon. So do not venture near to the Tarlov cyst with your needle in any case. This is my humble suggestion.
That's a great point, sir. Thank you, sir. Sir, and the next question. Ma'am, sorry, ma'am.
What clinical presentation of Tarlov cyst?
Clinical presentation.
Ma'am, in my experience, I have just seen one case. That patient came to me typically with S1 radiculopathy. She was complaining of low back pain, gluteal pain radiating to lower limb along S1 distribution, and she was also having claudication. So I told her, get an MRI done. You are most likely having a L5S1 disc problem. And even when I did a McKenzie test, which is a test used for checking the annular integrity, that pain was decentralizing. So I was very pretty sure that she was having an annular tear, and I was expecting an L5S1, but it was a very good lesson to me. Her MRI turned out to be a Tarlov cyst.
Yes, it's very right. Actually, for the Tarlov cyst, it is usually the incidental finding without any symptoms on the MRI. But when they are symptomatic, they can present as the radicular pain, most likely. Otherwise, they remain silent, just the incidental finding. I have seen quite a good number of cases, and I have seen sacral canal filled with multiple Tarlov cysts. Most commonly is the sacral region, but it may also present up to the lower lumbosacral region in the transitional zone also. So they usually present with the radicular pain, but unfortunately there is nothing much as a pain physician we can do for them. And most of the time my neurosurgeon friends have also declined to do any surgery on them because perhaps there are not great results. There is a high chance of decays post surgery also. So this is my small contribution. Please go on, Dr. Vishnu.
Yes, sir. So the next question is from Dr. Sanju. Which instruments do you prefer for foraminotomy?
Till now, in my personal experience, I have used for foraminotomy. Suppose the fragment is at L5S1 region and it is in the central canal here. It is in the central canal, and your inclination for L5S1 is such that because of the facet and because of the iliac crest, your inclination is such that you are not able to catch hold the posterolateral fragment because you ultimately land up into the central area. So to get into the posterolateral fragment, you have to go through the superior articular facet, or you have to ream, or you have to cut the superior articular facet. Then these instruments like reamers and trifines are used. Or what I feel, because these reamers are a little bit rough to use, and if what I feel, the Tom Shildley reamer, which there are serial reamers Tom Shildley Hoogland which has made, and they are very absolutely. What I felt was they were very good, and you can always see how much facet is being encroached. And when you encroach, when you ream the whole facet, and last end you reach, because the tip is blunt, so you are not going to injure the nerve, and then you ream the whole facet, and then again you put your scope. So there are reamers which gradually, there are 3 reamers, and you gradually ream up to the size of your working sheath, and you ream up, and then you put again your working channel, and then you put a scope. So these are used for cutting the superior articular facet or the foraminectomy, you can say it.
Yes, sir. Actually, apart from this, sir, we have also got this diamond burr, and which is a fantastic one. And this diamond burr gives a precise thing of the superior articular process. Basically, foraminoplasty, Dr. Sanchok sir, foraminoplasty, while you are doing foraminoplasty, you are taking out the tissues that is hypertrophied or ossified tissues which are present above the superior articular process. And this diamond burr, which I used in recent cases, that gives an excellent result. And this diamond burr will, like what to say, you can have the feel. It itself says, and the amount of tissue that you take out by using each and every burr. That is, it takes around 3000 RPM, and with this 3000 RPM, there is least chances that even if you do it for 30 microseconds, you can take out less than 0.5 millimeter of the tissue. And so the chances of neural injury is also very less. And whenever you use a diamond burr, you remove the tissue, and once you come back, see the endoscopic view, identify the structures, and then go in. So
I think this is more controllable. This is very much controllable diamond burr, and very in very small amount you can remove the tissue, and then you can reassess, and then you can again remove. This is very fine control actually. The diamond burr is very fine control.
Yes, sir. Sir, can I go for the next question, sir?
Yes, please.
Yes, sir. And it's from Dr. Murali Krishnan, sir. About epidural lipomatosis, can epidural steroid injections result in it? Our neurosurgeon opinion is that it results in epidural lipomatosis and fibrosis, which can cause problems with later surgeries. Sir, sir.
What I see, when apart from pain physicians, I have seen people putting epidural steroid in 5 to 10 times the dose the pain physician puts. See, when you are putting the steroid where it is exactly needed, the level, suppose there is a 3-level disc bulge, and you know that after your examination, you see that there is only one level which is symptomatic, rest 2 are asymptomatic, and when you are precisely placing your drug, you may need only 20 milligram of depot steroid to give a very good result, or maximum of 40 milligram. If you put the 80 milligrams of methylprednisolone and you put every week for 4 weeks, then definitely if you put in such a wholesale amount or quantity of steroids, like our many of the colleagues, non-pain physicians and surgical colleagues, we have seen putting 80 milligram of steroid and they repeat every week for 6 weeks. If this tremendous amount of steroid you put, then definitely it can cause epidural lipomatosis. But as a pain physician, when you do a precise work and you do a small amount of steroid when you place precisely the where it is required, I don't think it will result in the epidural lipomatosis. This is what, when you practice is unscientifically and unethically, you put your steroid every time when the patient complains of pain, you put steroid there without knowing where you are putting it and how you are putting it and what dose you are putting it, then definitely it can cause.
Sir, and one more thing, this epidural lipomatosis, it is a chronic condition. First of all, the name itself defines it as a chronic condition.
Chronic.
Yes, sir. So, if a patient comes to you and if you are examining the patient and if you are identifying the pain generator, And before, during, for example, if he's having a leaking annular tear, or if he has got a disc bulge with foraminal stenosis, where you want to give a temporary relief so that you can go for a definitive procedure, then you may go for single shot of epidural or twice. But repeatedly, like as Sir said, Devendra Sir said, if you're going to give multiple times, these are the endocrine changes, basically, which is called as epidural lipomatosis, which can cause severe adhesion. Like how general surgeons, when they do laparoscopic surgery, if they have too many adhesion, they do take a prolonged time. So similarly, it happens with neurosurgeons as well. So better we after identifying a pain generator, just to treat the patient conservatively for once or twice and then go for the definitive procedure. And with these things, there are like 0% chances of developing epidural lipomatosis with these pain interventions.
That's very true.
Yes, sir. Sir, the next question is from Dr. Anup Datta, sir. May I know the advantages and disadvantages of the different size of working channel in different approach?
Actually, I have not got experience for the interlaminar approach. Maybe Dr. Anurag will be definitely better be able to tell for this question.
No, actually, there are disadvantages. I don't know, but advantages are there. Certainly, you need different size of working channel for if your scopes are of different sizes. Like currently now we are having different endoscopes for the different approaches. Like for the transforaminal approaches, we have got 21 centimeter to 18 centimeter scope, and with the channel ranging from 3.6 to 4.3 working channel. So obviously the size will be different in that. Tapered working channel are most commonly used for both transforaminal as well as for the interlaminar route. At interlaminar route, they are bigger. If you are doing the stenotic work, they are bigger endoscopes, so certainly they require bigger size of working sleeve. But most of the time we use tapered working sleeves. And I would like to call upon Dr. Sushil Jaswal from Varanasi, who is doing a lot of endoscopy work. So Sushil, can you please come in and say a word about it?
Hello, may I audible, sir?
Yes, you are audible, please.
There is a lot of the endoscope for transforaminal and the interlaminar. The transforaminal scope varies from the internal eye, especially to the working diameter. It's vary from 2.5 to 4.3. At presently, they use 2.5 to 4.3. And the most common one is the Stones one is a 3.6, and the Wolf is a 4.1, and some newcomer is a 4.3. And this depends which level you want to work and what is your exact procedure. You want to foraminoplasty, you want to discal procedure. They depend upon their sizes. Like in a foraminoplasty and like a stenosis, the transforaminal people use the 4.3 because they can use drill of the any size 2 to 4 and the Carrison punch, which is very useful in a stenosis procedure, is a 4 up to 4, and the regular procedure is a 3.5 to 4.1 is a good for any procedure.
Dr. Sushil, question was basically about the working sleeve. So please say a word about that also. Yeah.
Sleeve is also the scope size. This sleeve is variation. Like a general scope is a 6.5, like Stones one. Then the sleeve is a 7.5, and the Wolf one is a 7 mm. And then the sleeve size is a 8. And 4.3 is also sleeve size is 8.
Yeah. No, what about the tapered end and the blunt end or the double pronged end of the working sleeve?
It's also depend upon the where is your target. If some people use the uniportal bilateral decompression, then your sleeve is a long tapered one. And if you want to use only foraminal, then are extra foraminal. Then is the very blunt, matlab is the taper wind is small.
Okay. So I hope that, Dr. Vishnu, please go ahead.
Yes,
thank you, Dr. Sushil.
Sir, thank you, sir, Sushil, sir. And sir, Dr. Anup Datta, sir, I just want to add one point. See, sir, I'd like to share my experience. Even I am a beginner. I just finished my course 1.5 years before, and when I entered, so what from my experience I would suggest is you will be following a philosophy, okay, from your master. Please use that set of instrument. If he is using that, you use that until you get a proper understanding, until you get a 3-dimensional orientation, until you get a proper hands. This is what I would suggest, sir. In market, there are like thousands of different sizes, like Carl Stoss 3.6, Wolf 4.1 scopes, different size of scopes, different instruments, everything. But please, just for the initial stages of our establishment, I would request you, please follow the philosophy of your master, because that knowledge which you gain from your master, what you gain from them, you are just putting it towards the patient and what they think, and similarly your ideology will be there for your initial cases. Once you become like a full, very experienced person, you can move on and you can explore different things. You can read the literature and find the advantage, put it over the patient, and then you can follow. This is my suggestion.
Thank you, Dr. Vishnu. Please go ahead with the question.
Yes, sir.
Sir,
yes, sir. Next question, Dr. Sanjog. What is the plan of action for patient of low back pain whose MRI only shows modic changes and we have ruled out other causes of pain?
See, if it is only the low back pain and modic changes when they start, definitely the first thing is the facet joint which are affected. So your patient has to be put on exercises. The ergonomics of his work has to be changed, and if the patient doesn't respond with the exercises or the usual medications, then you can go for the intra-articular diagnostic test for the facet joint, and thereafter you can go for the radio frequency ablation of the median branch so that he can get relief of the low back pain. Then the second thing after the facet joint, which may be presenting as a low back pain, which is in discogenic changes. The discogenic changes or the interstitial disc disease is where you need to get the annuloplasties, or you need a radio frequency of the annulus fiber to get rid of the discogenic pain. There are different set of procedures which are used for the discogenic pain. Nowadays, radio frequency ablation of gray MI communicants can also be used for the sympathetic mediated discogenic pain. So there are different procedures. You can undergo even the discography to determine which level is the painful, and then you can plan your procedures. So the discogenic pain and the facet joint pain, they are the two main entities which go for the low back pain, which is a non-radicular component. And definitely every time with your careful history and examination, you can find what is the cause of the low back pain without radicular component, and then accordingly you can plan your.
Okay, sir. Sir, and one more point I would like to add. See, modic changes are always suggestive of degenerative changes within the vertebral body as well. And now, see, whenever this happens, ultimately, this will be superseded by the discogenic changes. So it is not possible to only have modic changes in the vertebra, then being the disc being entirely completely normal. And apart from this, if we diagnose the patient is having vertebrogenic pain, then we can also go for vertebrogenic nerve block, or recurrent branch of the sinovertebral nerve block can also be done, and just to identify it, sir. Gray rami communicants block is also there, and L2 nerve root block, which carries all the pain from the discogen, can also be done, sir. Sir, and the next question is Dr. Samriti ma'am. Can we as pain physician do anything about the symptomatic Tarlow cyst?
Until now, in my experience, I have not touched the Tarlow cyst, and neither I have seen my patients whom I found the Tarlow cyst, which was asymptomatic, and I didn't find them. It was a major concern, and as a pain physician, as just now recently when it was asked by someone, we have discussed already Tarlow cyst in detail, and Dr. Anurag also told about them, but these are mainly present in the sacral area or in the lumbosacral, lower lumbosacral area. Mostly they are asymptomatic, and when they are symptomatic, they do compress the thecal sac or the spinal canal, the thecal sac. There has to be then the neurosurgical interventions for these Starlog cysts. As a pain physician, I don't think much of the time these Starlog cysts bother us, or the symptomatic changes are those because of Starlog cysts. As Dr. Vishnu told a very good case where it was mimicking as L5S1 symptomatic radiculopathy. But
Yeah, I think we have already discussed it in detail. There is no point in repeating that. Vishnu, please go ahead with another question.
Sir, from Dr. Nasir Ahmed Kulvligi, which disc is the indication for endoscopic discectomy, and for which one for transforaminal steroid injection?
See, the transforaminal steroid is for getting relief of inflammatory pain. If you think that patient has an inflammatory pain, and on subsiding an inflammation, because it is a chronic process, he may get relief for few weeks or months, then you can plan for your transforaminal steroid. It is never transforaminal steroid is never a replacement for endoscopic procedure, because endoscopic procedure is definitely planned when there is a definite mechanical compression of a fragment over the nerve root at various places, whether it may be a central or lateral or far lateral. But there is this definite mechanical compression, and in those cases, if you find the neurological deterioration is there because of the symptomatic compression, then you plan for your endoscopic procedures. But a transforaminal approach, if the patient is idealistically for endoscopic procedure and you put a transforaminal, I don't think it will do any good, because it may get relief for 2 or 3 days or maximum for 1 week. As soon as the axial loading starts, again the patient will be symptomatic. So you never replace a transforaminal for an endoscopy. But if there is a chronic, if there is a diffuse, if there is a lateral vessels narrowing, and you find that it is an inflammation which has aggravated an ongoing chronic process, you understand? If there is an inflammation which has aggravated the already undergoing the chronic process, which is leading to the symptoms now, so you can plan for the transforaminal and epidural neuroplasty, which will definitely give relief, because there was an aggravation in between a long chronic history. Then it will definitely get good relief. But if you see that it is a replacement for an endoscopic procedure, then I'm sorry, it won't help. The patient won't get relief.
So that means that you are saying that for the diagnostic as well as prognostic purposes and to provide acute relief in a patient, transforaminal epidural injections are good step. But for the definitive treatment, endoscopy is a better one.
Definitely.
We have also seen, I was a bit surprised what I am telling, but we have in last decade, almost a decade of practice, we have seen that many patients, when we have seen the MRI and examined them, we told them, nah, this is a definite case for us endoscopy, because nothing less than endoscopy will relieve. But we see that the last 10 days or a week, the symptoms or the neurological deficit is not increasing. Patient, due to his financial constraints or any other factors, is not ready for an endoscopic procedure. Whatever you trying to convince, then we have given transforaminal neuroplasty. We have done transforaminal neuroplasties, and this is what a medical science says, that you never know. We have also seen patients, these type of patients, where it was very much mandatory, and we have counseled them, and you have put a transforaminal steroid, and after a year also they are normal. Then what to do? So definitely for acute relief, you have to plan a transforaminal epidural, so that patient can get relief. It will also get relief, and your diagnostic point will also be strong, that the level which you are going to plan a transforaminal endoscopy will be a correct level or not.
That's fantastic, sir. That was the best explanation.
Hello.
Hello, sir.
Anurag Ghosh, your voice is...
Yes. Yes. I think the questions are over.
Yes, sir.
So, please request Dr. Sarita Singh ma'am to say a word as the coordinator of this session.
Ma'am.
Yes, Dr. Anurag, this is very useful and very knowledgeable presentation. And I think most of the pain physicians will be benefited by this presentation. And lastly, I would like to conclude this session.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
So, I will take just one moment of your attention. That Indian Society of Pain Clinicians is conducting this limited series of percutaneous spine endoscopy. Last week we had the overview of spine endoscopy. This week we have completed the MRI reading and the instrument. And from the next week we will go one by one clinical approaches. The next session will be on the transfemoral approaches of the spine endoscopy. Then it will be the interlaminar and advanced. So please visit for the past webinars to our website, that is www.ispc.in. And with this, yes, I just told you, Dr. Sogatri, that you can visit our website for all the webinars. There are the videos of all the webinars. And we are sharing them on our Facebook page also with the same name, Indian Society of Pain Clinicians. So there also these webinars can be accessed. So these ISPC Gurukul program has been designed keeping the interest of all the pain physicians, especially those they are in their learning duration period, and all the currents of anesthesiology, because pain medicine is being considered as a super specialty of anesthesiology, at least in India. We have got a lot of formal education as well as informal education available for all the residents as their career option. So with these words, I would like to thank Professor Sarita Singh ma'am from King George Medical University, Lucknow, Dr. Devendra Singh, the speaker of and renowned pain physician of Lucknow at Sahara Hospital, and Dr. Vishnu from down south. He is doing a wonderful work, and we convey our best wishes in all his endeavors.
Yeah.
And Vishnu, you have
Thank you very much, sir.
You have run the show with remarkably ease and competency.
Thank you very much,
I
sir.
hope that our deliberation has been useful for all the pain physician and the listeners. I would also like to thank Professor V.K. Mohan sir, who took out from All India Institute of Medical Sciences, Delhi, who is our president-elect also. He took the kind time to participate in the session. I would like to thank Dr. Pankaj Surange, the Secretary of Indian Society of Study of Pain and the Director of IPSC India, who has taken active part in the discussion as well, and he has contributed a lot of scientific material in the chat. So that is also available for everybody to watch. Dr. Pankaj, are you there? Your microphone issue has been solved. Dr. Pankaj? I think his microphone is having some issues. Otherwise, I would have invited him to say a few words about this program. And I would like to thank Dr. Neeraj Jain also, who is also a renowned pain spine physician of the national as well as international repute. I would like to thank all the international as well as national guests who took time on the Sunday. They are regular in our all the webinars. We welcome you all and we thank you all. So with these words, with the kind permission of coordinator ma'am, we are closing this session for today. And we'll see you again on the next. This presentation will be by Dr. Siddharth Verma, who is also a PDCC and running a course fellowship at D.Y. Patil University, Mumbai. So thank you all. Have a safe and good weekend. Keep yourself safe in these difficult times of Corona. Thank you very much.
Thank you, sir. Thank you very much for the opportunity.
Thank you.